Ryan, and on behalf of the Communications Committee of the ASMBS, I would like to welcome you to another SOARD Journal Club. Once again, a reminder that this is a hybrid format, so in addition to this recording, there will be a moderated comments discussion on the ASMBS LinkedIn group. So please join, tag your colleagues, share comments, and ask questions. This is also eligible for SOARD CME credit for ASMBS members. So please do use the QR code to log in, answer a few questions, and get 1 CME credit. It is really easy. Today, we have a wonderfully thought out and well-written article titled Unveiling the Cost Effectiveness of Bariatric Surgery, Insights from a Matched Cohort Study. This was published in SOARD last year. It is such a vitally important aspect of surgery and, more importantly, of effective and durable obesity management that just doesn't get studied a lot. So I'm extremely glad that we are discussing this today. We have two of the authors who are well-known in the ASMBS circle, Dr. Julianne Lloyd, a private practice bariatric surgeon, and Dr. Teresa Lemasters, a bariatric surgeon in Iowa, who, amongst many other leadership roles, has also served as past president of the ASMBS. Joining us for discussion, we have Erin Rossi, who is an ASMBS Communications Committee IH member and a registered dietitian at Cleveland Clinic's Bariatric and Metabolic Institute. We also have Doctors Joe Eid and Kabir Mehta, who are both brilliant bariatric surgeons in the Kentucky community. Welcome, everyone, and thank you all for joining. I will now turn it over to Dr. Lloyd.
Thank you so much for the opportunity to present this paper. Just give me a minute. Let me share my slides with you guys. All right, can you guys see my screen?
Yes.
All right, perfect. So thank you for the introduction as well. As discussed, we are going to be talking about this paper on the cost effectiveness of bariatric surgery. So we all know that obesity has a major economic burden across all of our society, not only on a national level, but also international. If we look at numbers across the US population, the prevalence of obesity is actually getting increasingly worse. And that's within the adult population, but also with pediatric patients. But not only is the number of patients struggling with obesity increasing, but the extent of the disease has grown in that it's causing worsened problems with diabetes, high blood pressure, high cholesterol, sleep apnea. The result is a reduction in quality of life for patients, as well as a productivity loss. And ultimately, the expense from all of this disease burden is significant. This number, 260 billion with a B, is actually about 10 years old, and I can only imagine what it looks like if we were to update this figure. So how do we address this problem? And we have techniques already available at our disposal. So of course, there's lifestyle therapy, pharmacotherapy, but bariatric surgery in particular has been demonstrated to be the most effective and durable treatment. We've had numerous publications, landmark publications and extensive discussion on the fact that treatment with bariatric surgery helps to get rid of obesity as well as obesity-related comorbidities. So if we have all of this information, then why is it that not as many patients are undergoing bariatric surgery? Why is it so heavily underutilized? And I think a big part of it comes down to the cost, or at least concerns about the cost of bariatric surgery. And that's what we wanted to look at in this paper in particular. So patients who have obesity end up using a lot more cost or have a higher healthcare utilization than their counterparts who have a normal BMI. But if we look at it, the initial procedural costs of bariatric surgery appear high. You have to prepare the patients for surgery, actually perform the procedure, pay for anesthesia and OR time, and then the post-op care can also be expensive. The studies that have been published so far really have not given us a clear picture on what's going on in terms of the cost of bariatric surgery and whether or not there is any healthcare saving in the process. And I think that's partly because most of the studies were really small and underpowered, or they involved comparison groups that were not well matched. So we really don't know exactly how much bariatric surgery can help us from an economic standpoint. So this paper in particular that we're discussing today is looking at this. It's evaluating the economic benefits of bariatric surgery, looking at patients who have undergone surgery and comparing them with their matched non-surgical counterparts. As a secondary objective, we also try to identify the patient populations that would best benefit from this or who would see the largest cost savings from bariatric surgery. So this is a retrospective analysis. We're analyzing data from claims research, claims database, excuse me, which includes a large number of patients across the entire United States. It's almost 300 million patients that were analyzed initially. And from that population, we look specifically at adult patients who qualified as having obesity based on their BMI. And then we sorted those patients into two groups, those who underwent bariatric surgery and those who didn't. And then we compare the costs of the healthcare utilization of these patients over the 2 years following their index date. Now, for patients in the surgical group, the index date was the date of surgery. And for patients in the non-surgical group, the index date was the date on which they were diagnosed as having obesity. So this is actually the first figure from the paper. So as I mentioned, almost 300 million patients from this insurance claims database. And we excluded those who had any prior bariatric procedure. So this was really just primary surgeries alone that were included in the analysis. In the surgical group in particular, patients had to have their diagnosis of BMI to be included in the study. They had to undergo surgery between January 2017 and December 2019. So we looked at a specific time period. They, of course, had to, the surgeries that were included are sleeve gastrectomy, gastric bypass, and BPD-DS. Those are the most commonly performed procedures in the United States now. The patients also had to have access to prescription therapy. And then we had to have information about them from follow-ups or at least, some form of visit where we knew what was happening with the patient for at least 1 year before the index date and for 2 years afterwards, just so we can track their outcomes. In the non-surgical group, again, these are patients who didn't have bariatric surgery. They also had to have a similar BMI diagnosis, similar access to prescription coverage, and similar information in terms of their follow-up before and after surgery. These patients were exactly matched one-to-one to the surgical patients using these particular criteria. And if we look at all of the variables, so as you can see before, we looked at demographics, so age, sex, BMI, but there were 7 specific comorbidities that were evaluated, and these have in the past been demonstrated as related to obesity or becoming worsened by obesity. And then we also looked at patients' healthcare use, so their inpatient costs, outpatient services, and medication use. And then the primary outcome, of course, looking at total cost, but also subgroup analysis, looking at different types of costs. And then this is potentially one area of concern with the paper, and we can discuss this at the end. But patients who were the extreme outliers, so if they had cost that was less than 1%, they were coded or recorded as being at the first percentile. Or if they had costs that were greater than the 99th percentile, then they were recorded as being at the 99th percentile. And this was really just to try to minimize any skewing of the data. So we tried to make the groups as similar as possible and then did our paired t-tests, just typical statistical analysis with a significance defined as being a p less than or equal to 0.05. So nothing unusual here. And then, gosh, I feel like I've been talking a lot about the methods, so let's talk about the results. So from table 1, you can see our patient population. Again, so many patients in the original analysis, but once we got to our cohort, the numbers are a little bit lower. Now, if you look at the table in detail, you can see that patients who are in the surgical group actually have a higher BMI, right? So their numbers are much more heavily represented in the larger BMI groups than the non-surgical patients. And they also have a higher number of obesity-related comorbidities, so same thing again. And they also had overall higher total healthcare costs. So I think that this is a huge selection bias. It means that the patients who were selected to undergo surgery were already sicker than the patients who were put in the non-surgical group. However, through our one-to-one matching, we actually got really good comparison groups that were very, very similar. We ended up with more than 9,000 patients in each of the categories. So 9,400 patients in the surgical group, 9,400 in the control group. You can see that the majority is female. Again, that represents our typical bariatric patient population. And most of the patients had at least one comorbidity. In terms of procedures that were performed, there's an overrepresentation of sleeve gastrectomy, but that also is reflective of our current practice patterns. Most of the surgeries that are performed in the United States now are sleeves. And that fortunately, we didn't have any dropouts at all in the study, so we got complete 2-year follow-up on all of the patients. When we look specifically at the costs, so the overall total costs show paint a clear picture for us, which is that the patients in the non-surgical group actually have higher total costs. They have over $5,000 more cost per patient, and that's a 20%, or I guess I should say it the other way. The surgical patients cost 22% less than the non-surgical patients. And if we look at how these costs are distributed, most of the costs are actually focused on outpatient services and pharmaceutical costs. And that makes sense because we're talking about chronic diseases. So these patients may end up having more visits and requiring more medications. So I think that's probably why we saw this. So you can see almost $3,000 per patient in pharmaceutical costs and over $2,000 for outpatient services as well. Now, inpatient didn't show that much of a significant difference. So I guess these patients were not getting admitted more than their surgical cohort. And when we looked at what factors cause the highest cost differences, looking specifically at the variables, we found that, not surprisingly, patients who had metabolic disease ended up having the best cost savings. Specifically, patients with type 2 diabetes and fatty liver disease or MASLD, those are the ones with the top 2 categories in terms of cost savings after bariatric surgery. Now, these differences were not necessarily additive. So when we combined comorbidities, so if we looked at a patient population that had diabetes and the fatty liver disease, they actually had an even higher benefit. So their overall savings in healthcare costs was more than $27,000. So, I mean, these are big numbers that we're talking about, and this is per patient. So, I forgot to give the lead in here. I think this is kind of a big change in the analysis. So in that portion of the paper, we actually looked at the analysis that would happen or the cost savings that would happen after bariatric surgery. And I think it's important for us to make that distinction between the second part of the analysis where we're looking at including the cost of surgery. I think from a medical perspective, it's important to know what the downstream effects of surgery are, and including the cost of surgery in the initial analysis might cloud that. But payers in particular, like insurance companies, they may want to know exactly how much money they have to pay collectively for the patient. So in our second analysis, we looked at including the cost of surgery. And as expected, if you look in the surgical group, it's going to be more expensive if you have surgery initially. And we saw that there was an $18,000 higher cost for patients in the surgical group than in patients in the non-surgical group. But I think, and this is an important but, even when we included the cost of surgery, we found that outpatient services, again, these are the follow-up visits, and pharmaceutical costs were still lower in the group that had surgery. So that means that bariatric surgery still offers benefits to patients in the long term, or at least in the 2 years after surgery, that could not be eliminated by just the $18,000. We further analyzed the data to see if there is a break-even point. And using our predictive model, we see that out to 6 years, or I guess somewhere between 6 and 7 years, patients who undergo surgery ultimately start to cost less or have cost savings relative to the patients who do not have surgery. We further determined whether it mattered what surgery the patients had. So we did subgroup analysis by surgery type. And this kind of surprised me that the sleeve gastrectomy actually had the highest cost savings benefit. So this was more than 6,000. The bypass also did show some. The BPD-DS, I don't think that we had enough patients in this cohort to really make a statistical statement. Because if you'll remember, it was just over 150 patients in this group. But I think ultimately what this shows is that regardless of the procedure type you have, there is a benefit to doing surgery. So what do we take away from this? I would say undergoing bariatric surgery appears to reduce the healthcare cost by this 22% within the first 2 years after the procedure. We think that this cost reduction is related to the chronic nature of disease and, in fact, the metabolic nature of disease. And it's related to less medication use and less healthcare utilization in the outpatient setting. Again, patients with metabolic comorbidities, so diabetes, fatty liver disease, they demonstrate the highest economic benefit. And even when we include the surgical costs, even though the short-term costs may seemingly be, or I guess it's not seemingly, may be higher, we can see that there is a break-even point in the long term where overall patients who undergo surgery have a lower cost and a lower ultimate burden on the system. So with that in mind, I'm going to throw some really controversial stuff out here for us to discuss. The first thing I would like us to talk about is whether there should be some kind of earlier referral for patients. Does this actually support that? And I think so. I think that if at 2 years we're already seeing cost benefits, who knows what will happen at 5 years, at 10 years, at 20 years. I think some of the benefits that we see from the bypass in particular may just begin to become more pronounced at 2 years. So I think the data in the long term is going to support this. And why would we not want patients to improve their quality of life as soon as possible? And then the other thing, I have a couple more points for us to just kind of delve into later on. But now I guess most bariatric surgeons are a little bit concerned, but mostly aware of the fact that we have access to medications that are available to the patients, even though they are super expensive. But how does this change the landscape for us? Often GLP-1s are cost prohibitive for patients. They require lifelong treatment. Even though they have become very popular, I think that there are some risks associated with its use, especially in the larger population. I don't think that these patients are really being guided the way that patients in a bariatric surgery program are being guided. In addition, bariatric surgery usually requires one procedure. Sometimes patients need revision. But if we think about this comparison, is it with the introduction of medications, does bariatric surgery still remain a cost-effective option for patients? And we don't know the answer to that yet. We will find out soon enough, I'm sure. So just a quick synopsis of some of the strengths and weaknesses of the people. I think this was a very large sample size and not frequently represented in the literature in terms of cost analysis. So I think we were lucky to have access to this database. The use of exact matching was also beneficial in that, as I mentioned before, we got the patient populations in the two groups to be as similar as possible before doing our analysis. Um, we were able to look at specific healthcare categories and we identified subgroups that showed the greatest cost savings. So I think, all of that is great. But of course, there are some shortcomings. It is a retrospective analysis. We're using claims data, so it may not have the same granularity. It doesn't have as much clinical data available to us for us to define, for instance, the hemoglobin A1C in the patients after they've had surgery. There is a relatively short follow-up period. We only had data at the time out to 2 years. So, obviously that will change over time. But I do think that the information that we have underestimates the long-term anticipated savings. We don't have much information about medication, like obesity management medication use in the patient populations, and that could potentially also be affecting the study. And then, of course, there's always potentially confounding, especially if we don't have information on like social economic status and, all the granularity, as I mentioned before. So I just want to leave this slide up here as we go through our discussion, because these are some other things I want to talk about, but I would love to delve into it right away so we don't delay too much. So should I stop sharing then, or can I leave these up?
We can probably we can probably leave it up. Should be fine.
Okay.
Actually, you know what? Let's we can stop
stop
sharing,
sharing.
but we can talk. Yeah,
I'll
we
stop
can talk
sharing.
about it.
Yeah.
Well, first of all, thank you so much. This was a wonderful paper and just a wonderful presentation. What's commendable is just gathering and assembling such a large data set of what I consider as complex data and conceptualize it into an easily understandable written presentation. And then this presentation obviously just kind of highlights the high points. Just knowing the challenges of obtaining accurate healthcare cost data, what motivated you to study this in the manner that you did, and how did you go about approaching it differently from whatever else has been published in the past?
So this was actually a joint venture. And, as you can see, there were multiple authors on the paper. I think at the time, this was when the obesity management medications were coming onto the market and kind of catching fire is how I would describe them. So I think we really wanted to demonstrate that bariatric surgery still has a role in treatment of patients. We as surgeons know this, obviously, but we're biased. And I think that demonstrating it in this way really just kind of shows it in black and white. So that was kind of one of our biggest motivations. The database is maintained by a company, and we were fortunate enough to have access to it. I didn't have like all the details, but we were able to get enough to garner what we needed out of it and make our point in terms of showing that bariatric surgery is cost effective.
I'll just
Perfect.
throw in a couple comments too, just since I have a chance to. This is a claims database. And so I think that's important because knowing who your audience is, the insurance companies, but not just that, the self-insured or, employers. And when they're thinking about how they're going to provide coverage and where they want to guide people to. And, so I think that's why this is also a good, powerful database to use because it's claims-based. It is pre-COVID, so the world has changed since then, but I still think it's very useful and important data that it is applicable. And then another piece of it, of course, there could be follow-up studies, but the non-surgical group, if you notice, like over 50% were low BMI. And if you had changed the inclusion criteria to start at 40, I mean, we start at 35 because that's the indication for bariatric surgery, even without a comorbidity. But if you started at 40, I think you could demonstrate even a larger, cost savings. But we wanted to start at 35 because that's where the indication is. And so many people don't ever, especially now in the era of medication, think about surgery for a patient with BMI of 35. And so we need to continue to keep that in the conversation. So those were some of the aspects of this data set that I thought were helpful.
Great. Well, just to touch on the point that Dr. Lloyd, you made about early referrals, just because that's actually been one of my areas that I've been kind of knocking at our institution to try and change some of the flows. I'll start off with the other three. So Dr. Mehta, Dr. Eid, and then Aaron, at each of your institutions and practices, just the discussion or the education of providers that see patients in the community or eventually refer the patients, how are those conversations starting in terms of the awareness and the importance of educating patients about their options early?
Sorry, Joe.
Yeah, go ahead. Start off. No, I was going to say start off Dr. Mehta, Aaron, and then Dr. Eid.
Yeah. So at least in the rural community here, I've noticed that there's still a lot of bias with the primary physicians. They don't believe in surgery. I've given talks, I've given grand rounds, and the few that attend will be impressed with the data that we have available to us, and so I've been able to change a few minds, but not not at a scale that I would like to. Most of my referrals are coming either direct or after failed medical management or not adequate medical management. So I think there's definitely more work to be done there.
In my institution, we focus a lot on the medical education. When we get residents, fellows, we have a fellowship that is not only obesity medicine, we obviously have the surgical fellowship. Some of those folks go into general GI surgery, and sometimes they end up referring a lot of patients towards us in the end. But we do get some family medicine, internal medicine that'll spend a few weeks in our program, and we give them lots of information to go share when there are other rotations. And so really hitting the students has been helpful for us.
For us, it's, Kabir and I are both in a similar setting, and I'd say the bulk of our referrals come in as self-referrals or through social media or word of mouth. Actually, most of the primary care physicians, I hate to say, they recommend to not go through with it. The way the PCP is presented to the patients, oh, well, have you tried this and have you tried this? And it's like a year of trying a GLP-1 on somebody who's 500 pounds, expecting that they're going to, wake up 200 pounds after a year later. And it's like, we're really not putting it down. All we're doing is delaying the inevitable, and they're getting sicker as time goes on. And they finally come to us, and well, it's my last ditch effort. That's the approach now. It's the last ditch effort. But nobody talks about the durability of medications versus surgery, and what are the outcomes? I mean, everyone loses weight, but do you need to lose 60 pounds, or are you like more of a 200-pound patient, that has to lose that much weight, or are we addressing your metabolic disease and whatnot? So those are the kind of the caveats that I feel like a lot of PCPs are not talking to patients about. We've had actually patients who self-refer and they go back to their PCP for their annual visit. They're like, I don't think this is a good idea. It's like the other way around, right? So I think me and Kabir both see the same kind of patient population, and surgery still has a lot of bad stigma down here. I'd say in Southern Kentucky, at least. Varun,
You're muted.
Sorry, Dr. Lloyd and Dr. Lemasters, with this paper and the data that you have, has it changed your approach to how you maybe interacted with the hospital systems in terms of advocacy for, say, resource allocation or changing the practices where you all are?
Yeah, so actually, can I make a comment first about what, yeah, so I think what we're really missing is a culture change here. And, I think it helps when we educate students, as Erin talked about. So I think really we need to start at the medical student level if we want people to understand the benefits of bariatric surgery. And then I think we also need to change the minds of the patient. So it sounds like, Joe had mentioned that patients are already getting wind of this. And I think, I showed Serena Williams on the slide. I think she really has shifted the needle a lot in terms of people talking about obesity and almost normalizing it in a sense. I think that's too strong of a word because it still is not normalized yet, for people to talk about these things. But I think that's one of the benefits of having the medications available is that people are actually now talking about obesity as a disease and trying to treat it. I don't know so much that the C-suite has recognized that. I think definitely our publication showing that there is a numbers benefit to the organization will help. I think we need more of it, though. We need more publications that show that bariatric surgery is going to help organizations, help companies that provide their employees with insurance coverage. But I am not sure that we're there yet. I don't know. What do you think, Teresa?
Yeah, so lots of stuff to unpack in there.
Yeah.
So part of what I hope papers like this can help get to, we do have to talk about resource allocation because a lot of places are trying to pull resources from bariatrics. Bariatrics is dead, and that's really not the case. And I do think we need to talk about cost effectiveness and as Joe mentioned, durability, and what's your long time sustainable strategy, not just a flash in the pan kind of thing. So I do think that these help in those discussions and say, if you're really investing in population health, Kaiser, or some of these big systems, this is population health. This is how you move the needle in population health. I think hopefully papers like this and more coming, we have to change that conversation about, in this era of meds and surgery, where is the clear line of who needs surgery? Because there is a gray zone of people who could do well with meds that previously came to surgery, and some of them will still come to surgery, but they may be on meds for 2 or 3 years and then decide to come to surgery. So that group's a different discussion, but we need to be clear about the more severe disease, the higher BMI people. They need to come to surgery now, and there is a cost to waiting. And so I think we need to have the data to inform those discussions, and really start to draw those clear lines. And like I said, you see the bigger differentiation in the higher BMI, more severe disease people. Just like Julie said, you combine these comorbidities, the cost savings is really substantial then. We also need to have a conversation around converting people who have been on medicines to surgery. So 50 million people tried these medicines and more than 50% stopped them, right? So what are their PCPs saying? Oh, sorry, I don't know what else we can do. We have to be out there carrying our message because nobody carries our message. So, and we have to keep doing that, keep hammering it, but also crafting the message around, targeting those people, even on social media. Have you tried these medications and decided maybe they're not the right thing for you? We have another therapy that's more powerful and more durable and actually costs less in the long term. Come talk to me about it. So I think we really need to be understanding, we embrace medicines, just like Julie said. People are starting to be ready to talk about it as a disease. Less so the primary care doctors, just like, Dr. Mehta and Dr. I'd mentioned that they're more resistant than patients, on moving on. This is a disease. If you believe it's a disease, it needs to be treated with effective therapy, which is not lifestyle modification in these patients. And we need to move earlier on it, or you're really not treating the patient with evidence-based medicine, So carefully crafting that message, but being out there and saying it. And papers like this help. We need to get more papers out there in journals that aren't just our journals. And we need to be on the stage at meetings that are not our meetings, so that we're, expanding our voice and talking to more of the people who can be our allies. So lots of things there. But on your specific question about resources for surgery, this can help us push back when they're wanting to pull resources, talking about, look, and some programs are already seeing this. Numbers have leveled out, and sometimes they're increasing already Because if you have 50 million people and we only get 1% of that extra 50 million who weren't looking for treatment before, that's a lot of people. So I still believe, obviously, surgery is the best therapy, but we have to be able to get the message out better. And, you know, unfortunately, it's going to be straight to the patients because we can talk to the PCPs and we should, but that's not the lever that's going to move everything. So there's my little rant on your question. Long answer.
All valid. Erin, just on the topics of obesity medicines, now at your center, if patients are on medications, not looking at surgery, do they have the nutritional counseling that's going hand in hand? And where does the discussion of surgery kind of figure in that subset of patients?
Well, the conversation is early and often. When someone enters our program, we're a dual program. We have comprehensive obesity medicine, surgical. We have obviously the behavioral health, nutrition. They see everyone, and everyone is always reminding them, hey, like this is a great option for this moment. If this isn't the path for you, if you feel like you're getting burnt out on this, we also have this other great option with people you're already integrated with, that you are already familiar with. It's a smooth transition. There's no changing. But it's always a reminder at the bottom of the after visit summary. It's, by the way, you also have the intake form for surgery if you want it. It's never high pressure sales, but it's always part of the discussion, which is great because a lot of people do. After a few months, they say, I can't afford this, or my insurance is all of a sudden dropping me. And if you're not on the medications, what happens? You slowly trickle back up, and that's more, you know, discouraging to someone who's been given a magic pill and the magic pill disappears.
Yeah. Dr. Lloyd, just now I'm intrigued about the sleeve data because to be honest, I'm a little surprised that the cost savings were more for the sleeve. What might be the reasons for that?
Yeah, so I was definitely surprised by that too. But I think maybe that has to do with you know, the fact that with the sleeve gastrectomy, there's so many people performing it. The patients tend to come in and I feel like the experience is probably a little bit condensed in the sleeve. So like I was making the point before with the bypass, sometimes if we look at the benefits, right? So ASMBS, I'm sorry, I'm all over the place with this question, but ASMBS has a predictor on their website. So when patients come in, you can show them if they had a sleeve, this is what they can expect to lose in the first year. If you had a bypass, this is what you can expect. And I have to say that in my experience working with patients, the patients who have the bypass tend to lose a lot more weight than what's in the predictor. And actually, if you go out even further from that, you can see that with the bypass, the patients tend to continue to lose weight after the first year. So to me, when I look at the fact that the sleeve has such a high impact, I think we're just looking at too short of a time to really assess the benefit of the bypass. So I think if we were to potentially look at the data at 5 years, probably the benefits from the bypass would be so much more significant because considered, at least, you know, it was considered a stronger metabolic operation. So I think that we'll see even more benefit if we look further out.
So I'm going to give you the opposite view. I'll tell you exactly why the data showed what I would expect. So the sleeve is very effective and very safe. The chance of a reintervention, needing another endoscopy, chronic marginal ulcers, vitamin deficiencies, iron infusions, dehydration risks higher, bowel obstructions, multiple CT scans for abdominal pain to rule out an internal hernia every time they come in with abdominal pain versus with the sleeve, they don't necessarily have to have that. It is a long list of additional costs, specifically with a bypass that comes with that. So with a bypass, you get more weight loss, but the sleeve hits all the marks you need to have to improve health, plus more. So yes, you can have a Ferrari and get there faster, but you can also get there in a VW bus cheaper and still get there and still get the benefits. And it may not be as flashy, and it may be 20 pounds less, even 40 or 50 pounds less. But guess what? The patient got all of the benefit from mortality, cancer decrease, diabetes improvement, even though, yes, diabetes remission is better for a bypass, it's this much, not this much. And we get excited about these things because we're scientists and we like to prove superiority and all these things. But there's actually a lot of data saying these things are equal at 5 years, 10 years.
I'm actually going to
It's
push
not,
back on that, Teresa.
yeah, there's lots. There's lots. That could be a whole nother discussion, but there's a lot of data demonstrating they're actually much, much closer than farther apart. And we like to get into the weeds about those little details, but for the patient and for their life and cost, what we're talking about here is cost and their future cost and their long-term cost. And all of those pieces go together to answer your question. Why was the sleeve more cost effective? You hit all the cost issues you needed to hit without adding additional cost. Now, we didn't say which one has the best number on the scale at 5 years or 10 years, because actually for most patients, they may care, but that's not what matters for their reduction in those comorbid conditions, their health, their mortality. They are still going to do great. They're going to live longer, healthier, higher quality of life with a sleeve. So I'm not saying that every patient needs a sleeve, but I'm saying that's why there's the sleeve wins in a lot of categories. So
Okay, so
we get very hyper focused on the differences, but
I will grant you that. So yes, I do agree with that part. But I also think that if you look at um, the trajectory of the sleeve, I think that there are many more patients who need a revision after a sleeve in the long term. So they may not, you're right, they may not need the dilation of a GJ
so
strip.
again, I'm going to push back on you. Need a revision. It's because somebody told them they're supposed to be at this weight and they're not there anymore.
No, no,
They
I'm talking
didn't
about,
need a revision because their diabetes came back. Some did, but that's a small number. They didn't need a revision. A lot of times, yeah, they had heartburn, but they really wanted to lose more weight. So they had a revision, but they could have taken an acid reducer and been fine on that acid reducer. There's a lot of variables that go into that need a revision. And guess what? We have medications. And so if you give those medications to sleeves, they do fantastic. And they didn't have the cost and risk and the additional procedures too. So, but I mean, I'm not saying like every patient needs a sleeve. I don't want you to think that. I just, to answer your question about why does the sleeve win? It depends on what is your ultimate variable. Is it mortality reduction, comorbidity improvement, and cost, safety? The sleeve is going to win every time. Every time.
And I think just I see Dr. Eid
I'm about to
excited
jump in on this.
because we share the similar population and we've discussed this in the past. But I'll let Dr. Eid and then Dr. Mehta share their experience as well because I think
Yeah.
it's consistent.
You know, when I first came out of training, this was like 6 years ago. It was all about we got to bypass everyone, right? Yeah, that's great when you work in a university hospital and every patient's not a smoker. But when you go out to the community in Southern Kentucky, where half the patients are underserved and on Medicaid that can't afford their vitamins, the only good reliable option actually that is left behind is actually sleeve gastrectomy, which is a great option. I will even push and say that, you know, just like you said that on the bypass, you see that there's over expectation with that trajectory curve that you see on the ASMBS website. I've had several patients beat that number easily with a sleeve gastrectomy. I think you see that both ways. I agree with Dr. Lemasters that I mean, anecdotally, I don't track my data specifically, but I can tell you that we scope more patients who have bypasses because of ulcers. We scan more patients because of these random abdominal pains they have, because you're trying to make sure you're not missing an internal hernia, because legally you can't not scan them. And then you're kind of caught in the middle of that. So you end up multiple scans. And over a 5 year period, I can easily see how cost, just pure cost, becomes much higher to maintain a gastric bypass patient. I will even push back and say, I see less phone calls and random pains with SADIs now than I do with bypasses even. And I think over the long run, we'll see that SADIs are even, you don't see marginal ulcers as often. You don't see these random pains here and there. And other than just adding like a cholecystectomy to the cost of a SADI, I think over the next 10 years, we will be able to see that even that's going to be cheaper than a gastric bypass.
That's great. I agree.
You hate to agree, but you agree
I
though.
hate to agree. You can see the reluctance on my face. I hate to agree, but I agree. I understand completely. Dr. Masters, you made a lot of, power-packed comments there. I wish we had time to go over every single one of them and have a one-on-one discussion. It'd be awesome. But a couple things I want to mention. One, first of all, congratulations to both of you, Dr. Lloyd and Dr. Masters, and other authors that are not here. This is excessively well written. I can be a harsh reviewer, and I had a hard time finding anything to say. But a couple things that I want to note. One, Dr. Masters, you'd said, go to other conferences, meet other specialists. I think that's fantastic. We're, at our conferences, we're in an echo chamber. We're not needing to convince each other. We need to get this information out. So that I 100% agree with. You'd mentioned, the hesitance about surgery is not just that the word is not out. There is just a hesitation about having an operation. You will see ophthalmologists wearing glasses, not get LASIK or whatever the newer procedure is. And you ask them, why don't you have this done? And you want me to have this done? I'll be honest. If I have to have an operation done, but if I have another alternative, I would probably want the other alternative. I know the low risk. I know in good hands, all the surgeons that are on this panel, all of you, I trust completely. I could be in front of you and I would trust you 100%. The lowest complication rates are here. But the hesitation exists. And no, I think the message that needs to be given out is obesity is a problem that's not being addressed equally or equivocally by medicines. It's not being addressed. The metabolic syndrome is not being addressed by anything other than surgery as well. It's just not happening. So you may be hesitant. This is the best, the most durable option you have. So, and don't ignore it. Dr. Lloyd had mentioned something. We're starting to accept obesity just because a bigger proportion of the population has started to have higher BMIs. And so we start to just look over it. Just today, my nurse practitioner said, oh, this patient's tiny. BMI was 20. I had to remind her that is normal BMI. We're just used to not seeing normal BMIs anymore in country. A couple other comments on the paper. You've done the cost comparison. I'd say that if you did this paper in 2023 to 2026 population, the cost of the non-surgical group would be much higher because of a bigger proportion trying the oral, or not oral, but medical management and the injections. Even though the copay is going to be lower in the future, hopefully for those. The other interesting point I noticed was the moment you bring in the cost of the operation, suddenly the cost balance shifts, it flips completely. And that's interesting because your average cost went from, for a surgical group, minus 5,600 to plus 19,000, meaning average cost of the operation for the hospital was 24,000. And if you look at high volume centers, they're offering these operations with a certain number of pre and post-op visits for 10,000, 12,000. Once you get the economies of scale going and you actually truly measure what's it costing you to do the operation, the cost of the operation is much lesser than what is being billed by the hospitals. And that could be another 5-hour conversation why the hospital billing is the way it is. But that's reflected here. And if those numbers were, coming from a high volume center or a true billing of services and equipment and, products used, your cost should be much lower for having an operation done. And the last point I have is the database that's used, Meridiv. It says this is all paid claims and encounter data. So it doesn't include the copay, the out-of-pocket money that patients have to pay. Am I correct about that?
I think you might be correct. I think it's not included in there.
Yeah. So
But these
there
are,
might be.
remember,
Yeah.
these are through employers, right? So, there typically is a lower copay for these types of plans than getting something through one of the mega insurance companies.
Right. And my point here being that we might be missing some aspect of cost that the patients had to bear for the operation out of pocket. Particularly in my region, their copays are massive. It's 4 or 5, sometimes more than that, thousands of dollars. And that's not necessarily true across the country, but we're missing that analysis in this, and that might shift the balance a little bit if we included that. But that's all I have.
Great comments, great discussion, but we're almost approaching the hour. What I did want to do is just go around for some quick closing remarks on things that we haven't already discussed or that would be worth a discussion, which obviously we hope to continue on the comments, moderated comments discussion section. But starting with you, Dr. Lloyd, any other thoughts, things that I know you had a slide up, and there's certainly other valuable things that definitely merit a discussion.
Yeah, I'm just looking right now to see what was on there. I think in closing, I would say I'm really excited that we're having this conversation. I think this is something that's been missing, for some time. We haven't been talking about the cost and the benefits, and that really is something that speaks to the payers, but also to the public. I think that we are, to use Dr. Lamassis's terms, moving the needle a little bit, and Dr. Rogers, moving the needle. So I'm just excited that we're talking about this and we can show that there is actually a financial benefit to bariatric surgery. So I hope that patients can keep that in mind and, consider it to help make them healthy.
Perfect. Dr. Lemasters.
So we actually talked about doing a follow-up to this study. We needed to be far enough out from COVID that doesn't impact it. So that's kind of looking at enough years past COVID, but we're in a different era now. Just as mentioned with the, Wegovy and Zepbound got FDA approval for obesity after the study was done. Now I'll tell you, we were already using Ozempic and all kinds of things, prior to that. But specifically indications for obesity, GLP-1s, GIP, those are newer. And so it would be very helpful to have that incorporated, I think. And also the insurance climate has changed post-COVID. There are more high deductible plans, as you guys were mentioning, patient responsibility in the 5,000 plus range, where this doesn't capture that probably as well because this is probably the best insured. But I also feel like it's a pretty good real world example of where a lot of self-insured employers and insurance companies, where they think about where their clients live. They're not thinking about Medicare, Medicaid patients. They're not really thinking about, equitable access. But this is more real world data. But I think hopefully we can do it again. It's just a matter of what time frame we need on that lead in and the lead out time frame and the follow-up. But hopefully we can do it again soon and see how does it compare now, because it'd be very, very interesting to do that.
That sure will be. I'll wait for that. Erin, how about you?
Yeah, you guys both, again, you did such a wonderful job in this paper. I love talking about it, and it's exciting to see that just with the 2-year data, you have all this great outcomes. We know from Splendid, from Stampede trial, that long term there's these massive benefits that are available. I would love to see a 15-year post-op, 20-year, and see just the longevity impact on costs. I think there's so much room to continue this sort of study and grow it and really prove the impact that we can make. So really, great job.
Awesome. Dr.
Great study. Thank you very much for sharing that. That was actually really cool. My only thoughts are I'd love to see how the data would look if it was all CMS patients and Medicaid patients, because that's what a heavy Medicaid population that I have. These are like you said, these are the best insured patients. I would love to see what the opposite would look like if it was maybe it's the same effect. We don't know. And that would be a great idea to look into. And then the other point was, how do I tell my patients, hey, your care with bariatric surgery is going to be less if we do bariatric versus medicine? I mean, I know my patients would say, well, I don't really care if it's cheaper or not because I'm not paying for it. You guys are. So it's just one of those things where real life and all of that comes into play. But I think we've talked a lot about how the referrals and how do you get the referrals, all that. I think other than that, that was the first hurdle. The second hurdle is making sure that the insurance are not adding more hurdles to get bariatric care. And that's the hardest part, right? That's a whole separate, okay, you get them in the door. And then all of a sudden they have 7 million requirements
Mhm.
just to get them to a procedure that you're wanting. Well, of course the cost is going to be through the roof then, right? And we all know that that's the end play, right? I mean, that's what they're going to get, but you're putting all the patients through multiple hoops because you want to see if you can get out of it without an operation.
I'll just throw in one quick comment because I know we're about done, but just so you guys know, on a national level, we do have those conversations with insurers and with Optum, and they actually are on our side on this, on that.
Good.
Like they're starting to think about maybe we do have too many barriers because we'd rather have, especially it's very clear in diabetes, we'd rather have them have surgery because clearly GLP-1s are now first line therapy. And we'd much rather have them have surgery. But then that's our pushback is you need to make it simpler and streamlined, decrease the prior authorization process. We need to make this normal, not exceptional. This is
Right.
a normal, appropriate treatment. So just so you know, we are having those conversations and we keep pushing. None of these things ever happen overnight, but they are more on board than you'd think. We're just got to keep pushing.
That's great to know, actually.
Yeah. And if you
Definitely.
ever have conversations with medical directors, that's a good way to go too. Is like, you know, got to know your audience, and cost is an issue. And we need to streamline this to get patients, especially with type 2 diabetes, lower BMIs, into surgery rather than a lifetime of a multitude of insulin GLP-1s. And there is no maximal medical therapy for diabetes. You just keep adding more. You can have, 20 different things. You got to think about the cost of that. That's a lot. So, okay, that's it.
Dr. Mehta.
Oh, fantastic study. It's going in my presentation, the grand rounds that I give to all the medical providers. This is going to get added on and would be a great addition. So thank you all.
100%. I was going to say the same thing. I'm supposed to do this for the Southern Surgical Club that we're hosting in April. So this is definitely going on there. And I was essentially going to say the same thing about, the conversation with the hospital administration and insurances, because in and around Kentucky, that's again one of the things that we've heard is with federal funding being at risk, bariatric programs are the first to go away because the hospitals and the healthcare systems, for some reason, do not see the economic upside. And papers like these, data like this, I think it's absolutely essential to just drive this point in that long-term perspective, long-term horizon is what's important. And hopefully the changing eligibility criteria for obesity surgery is something that can be taken up by more and more insurers. So, well, I want to just thank you all for coordinating this time and joining this evening. This was a fantastic discussion. I thoroughly enjoyed it, and the paper as well. But please don't forget to join the ASMBS LinkedIn group. Tag colleagues. Some may not like it, but tag, post questions, comments. More controversy, the better it is. I think it's always seed for a more lively discussion. But thank you once again. You all have a wonderful evening.
Thank you.
Thanks.
Thanks.